My name is Dr. Edgar Ross, and my topic is trauma and pain. I have a disclosure for this talk. I serve on the scientific advisory board for Harvard MedTech, and they are involved in the area that I will be talking about. So, what is trauma? Trauma can be defined in a number of different ways. It doesn't necessarily have to be physical, it can be also emotional. It is a response to some event or experience that is deeply disturbing or distressing. It can be perceived instead of realized. So it can be interpreted, some event, by a person, even though that interpretation may not be entirely accurate or even be part of the reality. But it's still reality as far as the person's concerned. It varies in degree from simple to complex. It can be both mental, emotional, physical, and spiritual. It can have impact across all of those domains. Unfortunately, it needs to be addressed early. If it isn't addressed early, and so you have to ask patients when you see them about some emotional concerns about the trauma that you may be treating them for, in order to start addressing this trauma with them as soon as possible to avoid post-traumatic stress disorder, PTSD, which is much more difficult once ingrained to treat and represents a barrier to effective pain management overall. So SAMHSA defines trauma as either some circumstance or event that results in physical harm, emotional harm, and or even life-threatening harm. But the degree and the amount of physical trauma does not necessarily correlate with how a person perceives it. If let alone and not treated, it has adverse effects and impact on both the patient's mental health, physical health, emotional health, social well-being, and or even spiritual well-being. And some of this or all of these points can be negatively impacted by a person's history of trauma. Trauma can be, let's say, a workplace injury. It can be major injury of some sort, automobile accident or some other kinds of injuries. But it doesn't necessarily have to be one event. It can be small, multiple injuries over and over and over again. And this is known as micro or repetitive trauma. Secondary trauma can also occur, and it's been described as someone who's socially isolated. It can be depression, it can be anxiety, certainly the PTSD, but even surgery can be trauma and have lasting effects, even if the surgery goes well. So the emphasis on effective postoperative management of pain is very important and viewed in this light of what trauma might be and perceived by the person. Trauma places a heavy burden not on only the individual, but on families, communities, claims professionals, and claims management. So claims professionals and claims management are often organizations or people who are involved in managing some sort of medical legal complications after a person has trauma, be it work, be it in a motor vehicle accident or something of that sort. Many people go on their lives after having trauma without any lasting effects. So there are many people out there who are very resilient. And the resilience comes either from their background, from the support system, and how they view this particular event. But others will have difficulties. And so you can't just assume by the nature of the trauma, what happened, that this person may or may not have long-term consequences mentally from something. You have to ask, and perhaps they might not share it with you at first. And it takes a patient-doctor rapport or a treating provider and a rapport for them to sometimes want to share that with you. Traumatic experiences are associated with both a behavioral health and a chronic physical health condition, particularly those traumatic events that occur during childhood. And this brings up the important subject that traumatic events in childhood can have long lasting effects, perhaps even throughout a person's entire life, having difficulty dealing with other events which are emotionally sometimes difficult to manage. So, that background of what happened in their childhood has real impact and effects on perhaps a person's chronic pain, a person's resilience of bouncing back from some event. That needs to be recognized as well. The response is personal. You can't just put a person in who had certain kinds of symptoms in a particular algorithm and treat based on some overall characteristics of the person. So everybody's an individual when it comes to that. If there's a strong support system in place, perhaps no traumatic prior experiences, the person might have resilient qualities because of their mental state is healthy. They have many things in their life that support them. So it may not at that point even affect their mental health at all. But it's important to ask all these questions. And sometimes these questions can be used individually without and subtly begin to tease out what the person might be thinking. Certainly, mental health conditions which are pre existing, substance use disorders, risky behavior, all which are potentially risk factors for being involved in trauma, are very important to recognize. And that also can reduce the person's resilience and suggest to the treating provider that they may need more help than just the physical trauma that they had and treating, let's say, a pain condition. Because of these health concerns can present challenges in relationships, careers, and other aspects of life, we need to understand the nature and the impact of trauma and how to explore healing. So, as chronic pain doctors, it's not unusual to have, let's say, an injury, perhaps some surgery that's required because of that injury, and now they can't work and they're financially on the edge. They have a lot of psychological comorbidities, which goes along with chronic pain, commonly seen, both depression and anxiety. And all that can come together for a person. It makes it much more difficult for them to be restored and also get back to a functioning life that's healthy. Are there any particular characteristics regarding who might have an impact by trauma? Trauma really has no boundaries regarding age, gender, socioeconomic status, race or ethnicity, or even sexual orientation. I mentioned that difficulty and bad experiences during childhood could be abuse, it could be some sort of malnutrition or something else, can certainly set the stage for having psychological reactions to traumatic experiences. And so perhaps to some degree, socioeconomic status does involve or become a risk factor for that. But it's not necessarily only the people in the lower economic strata who have higher risks. It's all of us. Trauma is a common experience for adults and children in America. And it's especially common and much more common in people who have a history of mental health problems and or substance use disorders. So addressing this, addressing what a person feels about trauma is a very, very important part of the behavioral health care and should be an integral part of the healing and recovery process. And if you suspect the person has some emotional problems from trauma, it's important to ask, it's important to follow up. And you can begin to suspect somebody who has these symptoms that they may have not shared with you because of delayed recovery. So if it's patient's not progressing as you thought it might, these are some things to look into. So trauma has symptoms all of its own. And the psychological component of this traumatic experience results in the comorbid kinds of symptoms, which are psychological in origin, depression, PTSD. Chronic pain is itself a symptom of trauma, sleep deprivation, anxiety. And so many of these aspects come together and make the person's pain experience that much more difficult to treat. And so even we get a pain score from someone 0 to 10, where are you on a scale? The perception of a person's pain is altered if some of these other symptoms are also present. All right, so we talked a little bit about trauma. Let's talk about what pain is. And you might find that this subject matter is maybe a little unusual, or why are we talking about that? The IASP, the International Association for the Study of Pain, describes pain or defines pain as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. So let's unpack that just a little bit. So it's certainly an unpleasant sensory experience. That makes sense, and we understand that. And we've all had pain before, and we all know what that means. But the emotional component to it is also very important to realize. So, why is a person having pain? What's the underlying reason why that person is having pain? So, I often give an example to my patients. You have two identical twins, they're laying in the hospital bed, and both had cancer of the colon. So everything is the same for both people. They grew up in the same household, they were exposed to the same parenting, they had the same life experiences. One had surgery for cancer of the colon, and the surgeon says to that twin, we got it all, the cancer is gone, and you're effectively cured. The other one is told that they got most of it. The cancer is, as I've gotten excised most of the cancer in you, but unfortunately, some was left behind. It was a little extended beyond what we thought. But we have other treatment options. We have chemotherapy, we have radiation. So you would ask, same operation, same twins, same genetic background, who's going to have a more enhanced perception of pain? And so the answer is obvious. It's the person who feels that their surgery has been completely successful versus the person who surgery is a little bit less than what they expected, perhaps. And the other part of this that is really important is it can be associated with potential tissue damage. So meaning that the person may have pain, no tissue damage that can be recognized, and yet they can report pain. So as a pain doctor, we always accept a person's evaluation of pain as a given. We may do scans, we may do all sorts of lab tests, and the person's pain or origin pain is not understandable. That doesn't mean that they don't have pain. That still is a person who has pain and needs to be treated. But pain is a warning sign for tissue damage. And if pain occurs without tissue damage, we have to look elsewhere as to how to help this person. Acute pain is defined as pain lasting less than 3 to 6 months. It's actually often associated with soft tissue damage. In that setting, acute pain is a warning. There are people who are born without the ability to sense pain. Their life expectancy is actually short because pain is a very important symptom, a very important perception of that we need to survive. So acute pain has importance in survival and getting treatment and also just taking care of herself. But at a certain point, pain lasts longer than 3 to 6 months. This chronic pain problem, as it's defined beyond 6 months usually, is no longer a healthy symptom. It's no longer a healthy perception. It is now actually part of the problem, and we need to treat it. It's no longer telling us that something's wrong. It's telling us that we should continue to perhaps be less active, be, not involve ourselves in everything that we need to do. And so sending us a false message. So persistent pain and nerve signals that continue to signal to send messages to the central nervous system is pathologic after this problem is healed. And it also has physical and emotional factors that go on to cause debilitation. And so a person is much less active because they are treating their chronic pain as an acute pain problem. And so that itself becomes a health risk as a person becomes more and more debilitated, less able to move around, and all the consequences of that also begin to manifest as time goes on. Traumatic pain is a double-edged sword. Pain is a great indicator to indicate both the severity and the problem. Pain reduces the complications potentially because you're protecting, but also pain can induce severe complications leading to further deterioration of pain of a patient. Managing pain is a really important part of a systemic approach to trauma. And so we have to recognize that the pain is a warning sign, but at some point, that pain has to be managed in order for a person to be able to participate in rehab and getting back to life. There are many different ways of assessing pain. Pain severity scales could be 0 to 10, it could be function scales, and they're commonly and widely used in clinical practice. Pain assessment and management is one of the most important areas to pay attention to for the patient, because that's the most common reason why a patient may actually even seek medical attention. So there are standardized and practical tools that are widely available and can be implemented in anybody's practice. It's important when you're assessing a person with pain, what kind of manifestations do they have? How long has it been going on? The intensity, does it vary? Any comorbidities they may have, and also asking about both the physical, mental, and social life of a person, getting more details on the impact of pain. Why is pain assessment important after trauma? Well, inadequate pain management after trauma reduces the chance of a person returning back to work or even returning back to a productive life. It reduces a person's quality of life, and when a pain is poorly managed, particularly from trauma, it increases the risk of PTSD, which is much more difficult symptom psychologically to treat and can inhibit dramatically a person's recovery. Poorly acute pain also increases the risk of chronic pain. So if you have a problem that is causing pain and it's poorly managed, the central nervous system can actually adapt and change its responsiveness. And that change in responsiveness poses the risk of developing chronic pain and all the implications that I just mentioned earlier. So let's talk about pain and that sensory processing that occurs. We have an enormous ability to manage pain, which is innate and built in. And that's also a part of the need to manage pain on our own through our nervous system and all the humoral effects that we have to reduce pain when a problem occurs, particularly as when pain interferes with a person's survival. So there's been a great deal of work in this area and looking at the phenomena of pain. The question has been raised over many, many millennia. Why is it that someone may have such a significant injury and really have not much pain at all. And yet, a person who has even a trivial injury or seems to be trivial will have very severe disabling pain. And in fact, one of the founding fathers of pain medicine, Dr. John Bonica, was a boxer, but he also served in Korea. And he noticed and became interested in pain medicine in the soldiers that are wounded coming in from the front. And many of them had very little to no pain. And that was very unexpected because of their significant trauma. So something in us is able to modulate the symptom of pain. And so the first type of theory, the gait control theory, was published. It certainly has its principles are still very important. The first gait control theory was way too simplistic, as our ability to understand pain and manage pain and all the research that has gone on, we have now a much more sophisticated understanding. But this gait control theory serves the basis and the entrance point for us to understand how our central nervous system works when it comes to pain. Virtual reality can also interact with the gait theory of pain by providing sensor inputs that modulate pain signals and influence pain perception. So there are many different types of non-drug treatments that can alter this perception. I'm thinking of not only just virtual reality, but acupuncture, TENS units, even physical therapy, staying active, all go towards and can enhance the inhibitory effects of the central nervous system on pain perception. So in the lower corner, you can see a painful stimulus. When you have a painful stimulus, there are two different types of fibers, fast conducting fibers, A beta fibers, and also C fibers. The A beta fibers connect very quickly and directly for rapid communication to the brain to say to the brain, there's something here that is very painful and potentially dangerous. And so then we have a reflex arc that pulls our hand away from that. Later, the C fibers then connect. They're much slower activation and much slower conduction. And they begin the healing process by stimulating all sorts of mechanisms, increasing the immune system, and as well as protecting our extremity. For example, if you burn a finger and you feel the aching afterwards and you don't really want to manage that, move that finger, the C fibers are responsible for that. And so we also have some pressure receptors at the end of our nervous system. And we've all had the experience where maybe we've burned the tip of our finger, and if we squeeze the base of the finger, that squeezing sensation actually seems to block some of the pain sensation. So that's a great illustration of what the gait theory proposes to explain. Although, as I mentioned, that's way too simplistic from what we know now. So let's talk about that. Let's talk about the physiology of pain. And I'll bring that into the discussion we have about how trauma and the psychological consequences are very much intertwined with that. So we have specialized receptors at the end of our central nervous system. These specialized receptors sense different things. So it could be pressure, it could be heat, it could be pinprick, it could also be light touch. And each of these receptors then connects through to peripheral nerves that then go up through the spinal cord. So that's the initial receptors that we have at the end of our nervous system that informs us that something is painful. So from the receptors, it then goes through to the peripheral nerves. These peripheral nerves are then impact and travel to the spinal cord. So those nerves have multiple different functions. That incoming impulses from those nerves Then begins the process of swelling, begins the process of mobilizing white blood cells to fight infection. So all the things that we know that need to be done to heal an injury begins with the peripheral nerves sensing that something has caused damage. It is followed by the next step, and that's at the dorsal horn. So the dorsal horn is the location of the nerve cell bodies of the sensory nerves. And the sensation travels up to the dorsal root ganglion. And in fact, that's one of our targets for certain kinds of pain procedures, what are known as DRG stimulators, who can actually stimulate that dorsal root ganglion to block symptoms coming in from the periphery. Then there's also connects very quickly to a motor nerve, which goes right back out to the periphery. And that forms the reflex arc for us to pull back from that particular injury. And that's protective. In fact, it happens so quickly, we're rarely conscious of even that occurring from pulling back. The next step is the spinal cord. So we have the first modulating system that we just talked about, which is the dorsal root ganglion. Now we have the second location for potential modulation, and that is in the deep part of the parenchyma of the spinal cord. So we have a fast conducting system, the posterior column, and then we have slower conducting nerve fibers that go up the spinal cord as well. And then we also have different kinds of nucleuses coming down from the brain that can be used to modulate pain and reduce the symptoms. So these are, that balance very commonly keeps us in homeostasis. And when the danger or threat has now been survived or is gone, we can then use this to modulate pain. In fact, it also becomes some of our targets for medications and other approaches for management chronic pain. The next step is the thalamus. The thalamus is very, very important in perception of pain. So thinking back to the emotional experience that's associated with pain, this begins in the thalamus. It's one of the first stops from the ascending symptoms of pain from the periphery. But it also has multiple different pathways to other parts of the brain. So the hypothalamus, the pituitary, many of the emotional aspects of our makeup that this brain will control are all connected to the thalamus. And those secondary impacts of what pain does comes from there. And then finally, we have the cerebral cortex. So we've already gone up multiple different areas from the periphery through the spinal cord up to the brainstem, the midbrain. But until now, we don't have a label for this. We have not consciously perceived that anything is wrong. And it's not until it hits the brain where we have that conscious perception of tissue damage and or the possibility of tissue damage. The conscious thought of what happens when we're reacting to an injury is spread all over the cerebral cortex. There's planning, there's perception of how severe this pain is. It's our understanding of why we have pain and why this happened to us. It's the integration of that sensory system with the motor controls within our brain. What are we going to do about it? What do we need to do about it to avoid further injury? And then it's also the area where the emotional aspect comes together with our integration in what we perceive this pain to be. So the background emotions, like I talked about earlier from traumatic experiences prior to this, also factor into this and also are part of the integration of the entire aspect of what we perceive this pain, what kind of impact it is, and what we're going to do about it. So there are reward centers in our brain that are very important in this pain perception as well. So we obviously know about the reward centers. That's a site for potential drug addiction, for all the happy things that we want to do, promoting behaviors for survival, drinking, reproduction, et cetera. This is all what part of certain areas in the brain do. It's the ventral tegmental area, the nucleus accumbens, and the prefrontal cortex. And these are all part of a big circuit known as the mesolimbic dopamine system. And so dopamine is thought to be the primary neurotransmitter for these reward centers of the brain. And that's obviously when hijacked by maladaptive behaviors, drug abuse, for example. This is where this occurs as well. So let's move on to the next step in treatment of pain. So we can treat pain by pharmacologic approaches. It can be through medications, where we're taking advantage of the cerebral circulation, and the medication that we've ingested has gone through the digestive tract, have been absorbed, perhaps converted in the liver to something active, and now it's crossed the blood-brain barrier into the areas that were mentioned above, which are very important in the management of the pain. Because of the blood flow to the brain is much higher than the spinal cord, most of our oral medications have the impact on the brain. But we can also inject medications bypassing the digestive tract. So that can be either local anesthetics, can be certain analgesics, certainly opiates as well. The effect is much quicker because of that different approach. We can also target the peripheral receptors. So if we anesthetize the peripheral receptors that are triggering pain, such as a nerve block, we're blocking the initial sensation of pain. And so the spinal cord and the brain don't receive those electrical signals. We also can block this by anti-inflammatories. So non-steroidal anti-inflammatories are thought to work peripherally. But what's important also to know, even if we block sensation, that doesn't mean that we might not have discomfort or pain, because the tissue factors which are released by the trauma also go on to sensitize the nervous system. And so you may have completely numb extremity, and yet the person might perceive to be uncomfortable. And this certainly can be those tissue factors which are released during trauma. So we can also, beyond anesthetizing the peripheral receptors, we can use regional blocks. They work to block the sensation in transit. So examples of that might be peripheral nerve blocks, it might be epidural anesthetic injections, it might be spinal and anesthetic injections. We can also use systemic medications such as opiates, and these work primarily on the brain and block the symptoms that are coming in from the periphery. There are people who obviously self-medicate with opiates, and certainly that's a very risky behavior that leads to potentially further trauma and making pain so much more resistant to treatment when used medically. As I noted, there's non-pharmacologic approaches, and these will work for both acute and for chronic pain. So acupuncture, massage therapy, guided imagery, music, biofeedback, certain implants, spinal cord stimulators used on drugs, electrically stimulating particular branches of the peripheral and the central nervous system, and then virtual reality therapy, where a person may view in, let's say, goggles, some sort of pleasant scene, and that takes the brain away from the situation that they're are involved with. So we talked about how pain can get transmitted to the brain. Well, let's talk about how the pain modulation system the signaling that goes the opposite direction is impacted. So Descartes, long time ago, that little figure with the foot at his on the fire, hypothesized that there's a nerve that comes from the foot or the finger that goes to the brain. He did, at that time did not have the anatomy and all the things that needed to study it in detail, but clearly he set the basis for modern thinking in neurosystems and how the central nervous system works. We now know, if you take that figure and make it a little more reflective of what we know, that the red line brings the sensation of pain up to the brain. But there's so much modulation that occurs, prior experiences with that, attentions, expectations of why I'm having this pain. Is it for a good reason? Is it something that is therapeutic for me? Then the mood, both anxiety and depression factor into this. And then the neurochemical and structural changes that have occurred, even from way back, let's say in childhood, if someone, some child had a very traumatic experience, a broken home, violence, kinds of in their formative years, child abuse, all of that is carried forward to adulthood, never quite escaped from there. In fact, MRIs and brain imaging have shown that the important centers that modulate pain are different in people who've had, let's say, child abuse as a in their history. In fact, those centers are sometimes even atrophied. So some of these experiences, they will never, ever be able to get over because structurally their brains are different. And so it's important to realize from history that, in fact, what that person background is so important. It's just one example. And then there's this green arrow that goes down from the brain, down the spinal cord, through the peripheral nervous system, and all the modulating steps that I mentioned earlier. And that allows that person to modulate the pain based on a particular situation. So we have a balance within our central nervous system, just like we have a balance in all of our organs and every process in us and in biology in general. It's not just a one-way street. There are ways of modulating. We have our own innate pain processing center that can be changed and can be used as treatment. So let's talk a little bit about non-pharmacologic approaches. And cognitive behavioral therapy is a therapy that's widely used in trauma, can be used in PTSD and all sorts of other psychological conditions. Virtual reality can be used to enhance cognitive behavioral therapy. So the virtual reality takes a person out of the situation that they're in, puts them in another situation which they can find pleasant, and this can help change, reinforce thoughts, beliefs, and behaviors related to pain. This is not just even for chronic pain, this can also be used for acute pain. And there are a number of studies and growing literature that suggests that this virtual reality therapy, as other non-pharmacological approaches, can be at least as potent as medications. So virtual reality improves coping techniques, it induces relaxation. Remember that many chronic pain patients have a lot of anxiety. It can be used to modulate breathing, bring them into a meditative state, and also in distraction therapy. So the advantages of virtual reality therapy are several. One, it is safe, very little to no side effects. It provides a very controlled environment. It can prompt or set up a person to be able to enter an exposure therapy. It can promote relaxation, and it can be used to treat emotional states and make them and bring it down to less extremes. So improved emotional regulation. Virtual therapy promotes both relaxation, can reduce anxiety, depression. So many of the symptoms that perpetuate and enhance someone's pain problem can be reduced and can be used very effectively in an overall treatment program for a person's pain. The thalamus is one of the most crucial relay centers in the brain for pain. And that virtual reality therapy interacts with the thalamus in multiple ways, depending on how a person can absorb that virtual reality experience. But the thalamus is a very critical relay center for both ascending impulses of nociception or pain from the periphery, as well as regulating and enhancing downward regulation and reducing a person's perception of pain. We know that the virtual reality also interacts with the endogenous opiate system. It enhances the parasympathetic nervous system by inducing a relaxation response, getting a person away from the sympathetic activation that many of them have, and which is part of the traumatic experience. The parasympathetic nervous system is responsible for regulating body functions that occur during rest. And so that whole fight or flight experience that many of our chronic pain patients seem to be stuck in is reduced by virtual reality. So one can ask, how does virtual reality interact with the pain modulation systems? It's way beyond distraction, relaxation, exposure therapy. It's a part and parcel of a cognitive behavioral therapy program. It actually can change the way the brain reacts to certain situations. And fMRI views of how the brain functions under virtual reality shows, in fact, that this is actually can, with time, change brain chemistry, allowing a person to provide or engage in more healthy activities. So virtual reality affects a person's reality, enhances the analgesic effect by using the reward centers in the brain, such as similar to cell phones, social media. It has uses in both pre-procedural areas. A person might be anxious prior to going into the operating room. There's literature about that, and reducing the need for preoperative sedation for person's anxiety. Immediately pro-procedural or post-procedural or intra-procedural, virtual reality significantly improves a person's ability to tolerate people, particularly people who are able to engage in it. And it has been shown to be effective even on the battlefield, reducing the need for medications and analgesics acutely when a soldier gets injured. So with that, I thank you for listening.